Good afternoon. Good afternoon, and welcome to the Woodrow Wilson International Center for Scholars. Hearty welcome to you. This is not a church or a synagogue. You don't need to sit back there in the back pew. There are plenty of seats up front for those that come in the next few minutes. I'm Mike Van Dusen. I'm Executive Vice President of the Woodrow Wilson Center, and I guess I need to do that 2-minute plug on this institution. We're a public-private institution. We are the official and living memorial to the 28th President. Believe it or not, it's the only president of the United States buried in Washington. There's a trivia fact that some of you may want to know. He is also the only president we ever had who had a Ph.D. And as a university president and then as president of the United States, he always felt that you got better public policy when you got scholars out of their ivory tower and they had some understanding of the problems of running a government, and you got policymakers away from their inbox where all they can think about is a meeting next Thursday. And if you put scholars and policymakers together that they understand the issues from different perspectives, that you can move towards better policy. That's what we try and do here. We do two things. We convene meetings, of which this is one. We convene about 800 meetings a year. And the second thing we do is we bring scholars from all over the world to Washington to research and write, do their own research and writing, and to mix with people in this town. So that is what we are about. Our meeting today is the 6th meeting in a 9-part series on maternal health. And I want to start by thanking very much UNFPA and the Maternal Health Task Force for being our partners and funders in this enterprise. I also want to acknowledge, I believe that we have some participants that may be in another room here, and there are a lot of people listening to this online, and we appreciate their participation. I think my other and only other assignment is to thank Tim Thomas, the Senior Advisor at the Maternal Health Task Force. Thank him for moderating today's event. Tim began his career at the Population Council in New York City, where he's Special Assistant to the President. In 2005, Tim was appointed Executive Director of the Staying Alive Foundation at MTV Networks International, based in New York. As a global grant-making and advocacy organization, the foundation encouraged and enabled young people who were involved in HIV and AIDS awareness, education, and prevention campaigns, especially in developing countries. Tim, I'm going to turn it over to you. I hope you have a good afternoon. Again, thank you for being here at the Woodrow Wilson Center. Come back. Thank you.
Thank you very much, sir.
Good to see you.
Yes, indeed.
Thank you.
Not at all. Thank you. Hi, I'm Tim Thomas from the Maternal Health Task Force, and I want to thank the Woodrow Wilson Center for the hospitality for this and several of our other policy dialogue series. This is a seminal part of the mandate of the Maternal Health Task Force at Engender Health to convene dialogues on important issues around maternal health that we hope will further the conversation, both among policymakers and practitioners and, of course, donors, so we can see what the trends are in some of the more some of the neglected issues, we might say, and some of the more pressing issues that are challenging maternal health outcomes around the world. We're thrilled today to be focusing on the maternal, on the impact of economic development on maternal mortality and morbidity, and we have a pretty impressive panel lined up. I'd like to say a word of thanks to the Woodrow Wilson Center's Kaylin Ostrowski, who has been our partner in organizing these sessions and in finding such luminary panelists such as those we have today. Kaylin's over here. Thanks very much, Kaylin. A couple of housekeeping reminders. As always, please turn off all of your mobile noise-making devices, if you would. There is coffee, tea, and whatnot outside the door, and I think you'll all be able to find necessary facilities where you might need them. They're pretty well signed. So without further ado, I'd like to turn over to Myra Buvanich to my right, who is the Sector Director of the Gender and Development Group at the World Bank. And she has been addressing the economic impact of maternal deaths and the role of education and gender equality on economic development throughout her career. I recently encountered Myra as I was helping to rapporteur a ministers' forum at the recent conference, Women Deliver, where she gave, I think, this presentation or a variant thereon that was quite impressive to 40 to 50 ministers of health and finance from developing countries. And I'm glad that she's with us here today to repeat that that presentation and hopefully expound on it. Myra?
Thank you. Thank you, Tim, and thank you, Caitlin, for organizing this. It's a great pleasure to be here. It's a pity that Mike Van Dusen left, but I haven't seen Mike in like 25 years. But I used to see him because him and his wife and I were part of the founding members of the International Center for Research on Women. So you need to tell Mike that he used to look young then, and he continues to look young. I don't know how he does it, but it's wonderful. So tell him so. So anyway, let's just go on, and it's pretty much the presentation I gave at the Women Deliver conference that, by the way, was apparently just an amazingly successful conference. So let me just, okay. So, this has to do with maternal health, but goes beyond maternal health. This is some of the work we're doing at the World Bank. And the first and most important thing that I want to emphasize is that investing in women and girls is the right thing to do, is fair in terms of equality, but also it is smart economics. And this is what we have emphasized at the World Bank very much. And I will a bit tell you why it is smart economics. Why is it important to invest in women and girls? Here you have the relationship between poverty and gender equality. And as you can see, let me see if I can work this. Yeah, here it is. This is greater poverty, and this is greater gender equality. And you can see that there's almost a perfect inverse correlation. So at greater gender inequality, greater poverty. Obviously, this is not causation. You cannot say that gender inequality causes greater poverty or vice versa, but there is a strong correlation. But more importantly is that not only there is a correlation, not only we have a relationship between greater gender equality and less poverty in countries, but we have by now accumulated quite a bit of evidence on that, in fact, greater gender equality, increased gender equality in households, markets, and society has an impact on poverty reduction and growth. And this is the conceptual framework. These are the pathways through which, the evidence has shown, part of the evidence, and I will tell you what is the evidence that we have and what are the connections that we still need a bit of evidence. But these are the pathways. And basically, increased gender equality in households, market, and society, you have two different ways that affect greater poverty reduction and growth. The first way is really a way that is similar to men and women. When women have better access to markets, women have increased women's labor force participation, productivity, and earnings. This increases income and consumption expenditures in the household. And basically, this has a direct impact on current poverty reduction and economic growth. Something similar you might say if you have increased men's labor force participation in the same outcomes will happen. But here is where there is the added value of investing in girls and women. And it's this pathway. And this pathway is not shared with men. And basically, it says that increased gender equality in households, markets, and society, the first thing that it does, women have better education and health, and mothers have greater control over household decision-making. And the effect of this is improved child well-being. And basically, better health and educational attainment of children means greater productivity as adults, and it means future poverty reduction and economic growth. The one piece in this whole series of framework of pathways that we still do not have evidence for, or where the evidence is weaker, is on the part of economic growth, and particularly on the relationship with differential saving rates. We do not know if with increased women's labor force participation, it's increased income and increased savings by women that would affect economic growth. Okay, but let me show you the pathways through increased child welfare, and basically, and this has been quite a bit of evidence, and here I have evidence for 3 very different countries, Brazil, Bangladesh, and South Africa, where income transfers to women have a larger effect on children's nutritional status than similar transfers for men. And here you have this, this is what the measure is an anthropometric measure, is child height for weight or height for age. And basically this is when you give women more income versus increasing the income of men. Look what happens in Brazil. Income in the hands of the mother really has an effect on increasing child weights for height. This is a long-term indicator of nutritional status versus income in the hands of the father. Look what happens in Bangladesh. Actually having income in the hands of the father is even negative. And look what happens in South Africa. So if you're concerned about child well-being, and you're concerned about child well-being not only because it's the right thing to do, but because a healthy child will be a healthy adult and a more productive adult, it would make sense to give income in mother's hands. But there's another reason, and this is more recent, and particularly this is very relevant given the current financial crisis. Women help families weather economic crisis. And let me show you some evidence, and some of it is very recent, other is a bit old. But here I have 3 crises: the Latin American crisis, the East Asia crisis, and the current global financial crisis. And what you have in this is, basically, these are changes in changes in labor force participation rates. Again, the red is women, the yellow is men, and look what has happened in crisis. When crisis happens, households send their women to work. And in fact, we do believe very strongly that is the added worker effect of women that really keeps poor households below the poverty line and protects poor households in periods of financial crisis. So it's very important, and it may be counterintuitive, but in periods of crisis, to really make sure that women have economic opportunities. And these effects happen only for poor households. They do not happen for rich households. And look at this. This is the current global financial crisis, and this is very preliminary evidence that we're gathering at the World Bank. Look what happens in Cambodia with women's and men's labor force participation. Women's labor force participation increased dramatically. Look in the Philippines, Thailand, and Indonesia. The only country that did not behave in the same way was South Korea, in the East Asia crisis, where both women and men's labor force participation rates declined. So, now this is the other consequence of economic downturns. And basically, economic downturns are more detrimental to girls' health than to boys' health. This is a study of about 59 countries. These are periods of economic growth. These are periods of economic crisis. This, again, is infant mortality rates for girls and for boys. Look what happens when countries are growing, children of both sexes, infant mortality rates go down. So growth is good to reduce infant mortality rates of both boys and girls. When countries are in crisis, who are the ones that really experience the highest infant mortality rates is girls. This is very important, and it's very important also because this is not only a cultural response, because we do know that in certain countries there's a preference for boy children and they're the missing girls. But those are a few countries. There are probably 4 or 5 countries in the world. But this is 59 countries. So this is how women contribute to economic growth and poverty reduction, but we have a long way to go to achieve gender equality. Tim, you have to let me know when I'm going to be 5 minutes or so. There has been incredibly rapid progress towards gender equality in schooling. I mean, we have made dramatic progress. This is the MDG 3 of gender parity in schooling. We have still some countries off track in achieving gender parity in schooling, but there are very few. Yet, however, the transition from school to work leaves many girls behind. This is educational attainment rates. And you see that females and males are more or less the same. They both, are attaining lots of schooling, 80% at the age of 12. This is age ranges. But look what happens. This is when they labor force participation rates. When kids leave school, boys join the labor market, much more so than girls. Girls with high educational levels still have trouble joining the workforce. And men's labor force participation far exceeds women all over the world. This is women's labor force participation, this is men, these are the different regions. It's worst, the regions where the gap is the greatest is the MENA, the Middle East and North Africa and South Asia region. But, in all the regions in developing countries, you still have this gap in labor force participation rates, despite the fact that girls' educational rates have improved so dramatically. And while there has been some progress, maternal mortality rates continue to be high, and the gap in rates between rich and poor countries continues to be vast. This is the average maternal mortality rates for low-income countries versus for middle and upper-income countries. Look at the huge difference. And I'm sure you know the gaps there are so vast and unfair. And adolescent fertility is a risk factor for maternal mortality. And this is maternal mortality by age in a number of different countries. And the ones in the red are the 15 to 19-year-olds. So clearly, a large chunk of what maternal mortality is the deaths of young women who are giving birth and are too young to give birth. And adolescent fertility is also a risk factor for children's health. Here is mother's age is a big risk factor for children's health problems. These are mothers from age 12 to 14, 15 to 17, 18 to 20, and these are the different problems in child health. Clearly the younger the mother, the more the probability that the child will die, that the child will be underweight, and that the child will be stunted. But, there's another relationship also. Empowered women are healthier, and healthier women are also more productive. And until recently, we did not have data on the second side of the equation, that healthier women are more productive, that health leads to productivity. But look at this data. Health affects income, It used to be that we thought that health was the right thing to do, but maybe not the economically efficient thing to do. Well, that's not true. And here you have, this is percentage increases or decreases in women's income. And these are two different studies, one in Colombia and one in rural Peru. And these are indicators of women's health. This is adult height measured in centimeters. The taller the woman, so the healthier she is, the more she earns. And on the other hand, the more the woman is sick, and this is in rural Peru, the less money she makes. It is pretty obvious, but with this research really is a very reliable, it's a very robust research findings, and they control for a number of other effects. So now what do we do? What are the evidence of programs that work to increase women's economic empowerment and to make women healthier? This is a CCT program in Malawi, a conditional cash transfer program. Here they gave the money, the transfer, to the girls, to the adolescent girls in the household. The first time that they've given it to girls rather than to the mothers. And I don't know if you read in the Financial Times recently, but this is the study that they were talking about. Giving the transfers to the girls to keep them in school lowered dramatically the probabilities that they would get married, that they would get pregnant on the onset of sexual activity, and in addition, it's not here because it just came out that they would contract HIV/AIDS. So giving conditional cash transfers, not to the mothers, but to the adolescent girls, really makes a difference. And vocational training in Peru raised employment and income significantly more for young women than young men. This is Peru Joven. It's a very famous because of a very well-controlled program where we have a very robust impact evaluation. The effects of the program on employment and earnings of young women, they increased 93% in terms of their earnings versus 15% only in comparison to the male. So doing good vocational training makes a difference, and makes a difference particularly for poor adolescent young women versus poor adolescent men. Then the effects of female borrowing on household welfare. Again, this repeats the evidence that I showed you before. Basically, the impact of a 10% increase in borrowing from Grameen Bank, borrowing by women, that's the red, versus borrowing by men, that's the yellow. Look at the impacts on per capita household expenditures. Women spend a lot more on per capita household issues, and particularly in girls' height for age. So it does make sense to put money in women's hands.
5 minutes.
Now, 5 minutes, okay. This is a joint line titling program. This is another way, and it's a very, I think, easy way to increase women's economic empowerment. The World Bank is doing a lot of land titling programs in Africa, and we give out land titles. Well, we have realized that a way to empower women and to increase the productivity of land is you give the land title, but you leave the space in the land title for the name of the husband and the name of the wife, and the picture of the husband and the picture of the wife. And then the wife and the husband realize that they both jointly own land, and they're willing to invest more on their land, and women's power in the household increases dramatically. And ultimately, land productivity also increases. So this is a very simple way of tweaking a program to really give women control over property that is critical for productivity enhancing. A similar thing happened in Peru. An urban land titling program distributed 1.6 million titles in 5 years, and they gave titles to women as well as men. Look at the effects of the program on fertility and female employment. It reduced fertility significantly and increased the work hours of women in the workplace rather than in home. And now here is a childcare program that is also particularly important for women that have to go out to work. They created a lot of places for childcare, and what the program did in terms of primary school attendance and mother employment increased mother's employment dramatically. So what does it mean for public policy? And with this I end. First, you have to invest in the human capital of girls and women and foster school-to-work transitions. Help girls move to school from work. How do you do this? Conditional cash transfers programs targeted to girls do make a difference. Vocational training programs targeted to girls also make a difference. You want to increase entrepreneurship and access to credit, microfinance, entrepreneurship, land titling programs, all these things will give women assets. And you want to lower the cost of paid work through childcare, and you want to increase poor women's access to public works and employment generation, especially in times of crisis. And what do you do in terms of health? You want to reduce both supply and demand side constraints to have especially young women's access to family planning and reproductive health services. You not only have to work on the supply side, but you also have to work on the demand side for family planning and reproductive health. And working on the demand side is really working on the economic empowerment of girls and women. Thank you very much.
Thanks, Myra. That was, again, the second time around even more fascinating because I was able to digest more data. I think all of you should be aware that these data are on the websites, both the maternalhealthtaskforce.org and the Woodrow Wilson Institute. All three of these presentations are there for your reference, and I know that data like those that Myra have shown will be invaluable to all of us in various aspects of our work. Without further ado, I'd like to introduce Dr. Nomonde Kundu, who is a health attaché from the Embassy of South Africa in Washington. She has extensive experience in clinical medicine, policy development, public health program design, and implementation. In 2005, Dr. Kundu was appointed as cluster manager of the National Health Department's HIV/AIDS and TB program in South Africa, where she led the development of a multi-sectoral STI strategic plan. We're thrilled that Dr. Kundu is here as we're looking to have an overview from both Myra's position in collecting global data to Dr. Kundu's national perspective, and then our third one will present a even more interesting and diverse perspective on these issues. Thank you, Dr. Kundu.
Thank you, Tim, and good afternoon, everyone. On behalf of the Embassy of South Africa here in Washington, D.C., and the Ministry of Health in South Africa, I would like to thank the Woodrow Wilson International Center for Scholars for inviting me to speak on this very topical and important issue. I thought I should take a perspective that puts this discussion, this important and exciting and interesting discussion, in the context of the continent. I'll be speaking also to issues that pertain specifically to South Africa, and I'll cite some recommendations. I think it flows nicely from Myra's presentation in terms of giving the context and the quantification of the data that supports all of these positions. The outline of my presentation, as I say, will be that contextual space. Where are we now addressing these issues, knowing much as we do about this particular problem? The continental initiatives, I'll speak to that, as I say, South African situation and some recommendations. In terms of the global context, where is the discussion? I believe we have a sensitized, galvanized, and energized universe now around this issue. We have recently the G8 Muskoka Declaration, specifically coming out of that, paragraph 8, if you look at it, there is the Muskoka Initiative, which commits or plans to commit for the next 5 years about $10 billion worth towards dealing with maternal child and maternal, infant and child health. We have the Joint Plan of Action for Women and Children's Health coming out of the United Nations, signed and in fact led by the Secretary General of the UN himself. That is the context within which we're addressing this problem. We have recently the outcomes of the recent Mothers Deliver conference that was held in this city. We have the Global Health Initiative of the Obama administration expanding from where it usually or previously used to be only focusing on HIV and AIDS, and now considering where the world is in terms of dealing with maternal issues. We have seen the countdown to 2015 decade report coming out of the World Health Organization and UNICEF, which gives recommendations that are actually acknowledged by the G8 and others. We have recently come out of the 18th International AIDS Conference. I can't say much about the genderization of discussions at that conference, but we would need to look into that. I want to believe that that also came out strongly. We have the upcoming UN high-level meeting, MDG plus 10 summit in September. So it's a most opportune time to deal with these challenges at this point globally. In terms of the continent itself, notwithstanding, as you might well know, the issues of security that recent incidents in Kampala, Uganda, where the 15th AU Heads of State Summit was held, the theme of that conference from the leaders, the presidents of the African states themselves, was maternal, infant, and child health and development in Africa. Out of that, we saw a declaration coming, and they're talking action, action, action. The chair of the AU now is saying we've had too many declarations. We now need really to be action-oriented. And it's action on those issues, action for accelerated achievement of maternal, newborn, and child health and development. So it's a call for action. We have, coming out of that summit as well, the adoption of Women's Decade, 2010 to 2020. So women amongst ourselves here, this is our decade, according to the African Union. Africa, we have also Africa Progress Panel, which is led by Mr. Kofi Annan, which has done a considerable amount of work also genderizing the recommendations coming out of that. That, as you might well know, is the continent where I come from. I call it the 52+1 because we have only one female president in Africa. At least we do have one. So that's the 52+1. I need to speak to locate this in the African continent and what's going on, the spirit of karma. By karma, I don't mean some intangible energy from the atmosphere somewhere. I mean a specific advocacy strategy which was launched by the African Union in May 2009 to raise awareness and build links with international campaigns. And the theme of that campaign, in fact, is called Africa Cares, No Woman Should Die Whilst Giving Life. It's about positive messaging. It's about acknowledging and building on successes. It's about intensifying high-impact interventions. It's about promoting sustainable financing, strengthening partnerships. But what it does do, it's buttresses and bolsters continental policies and strategies, specifically the Africa Health Strategy, the Continental Policy Framework on Sexual and Reproductive Health and Rights, as well as the Maputo Plan of Action, which in fact has recently been extended from 2010 to 2015 so that it coincides with the MDG period. And this campaign has been launched in 20 countries continent-wide currently. So in terms of macroeconomic sexual and reproductive health in Africa, what do we know? Some of the data came out of Mara, as was saying. All of this now has been quantified. We know what family planning can do, preventing unwanted pregnancies, declines in fertility, and reducing induced and unsafe abortions, reducing other health expenditures, reducing infant mortality. These problems are inextricable. You can't separate maternal mortality from child mortality, specifically infant mortality and neonatal deaths. Improved gross national product is linked to expanding family planning programs. Maternal mortality, again, we've heard about the data that came out of the World Bank regarding this, but specifically just to say, women make up 70% of Africa's labor force, and are overrepresented in the agricultural sector, producing 80% of food, especially in rural areas in Africa. Death and disability, therefore, is a direct cost to the economy in these particular regions. Gender dynamics, we can't overstate this issue. Gender inequality remains an issue in the labor markets. There's higher unemployment amongst females than compared to their counterparts, males. Poor access to labor markets, we've just heard. We're just reiterating. You can't reinforce this message enough. Vulnerable employment, unpaid care work, that it's mainly done by women, especially in households, which are heavily engaged in household activities. Insecure employment with low earnings and low productivity, and it's mostly not by choice. In some instances, it's discrimination, it's cultural. I'm happy to say that this is not as rife as it previously used to be in the continent. There's been some progress and improvement in this regard. But then it's linked to differences in skills, in work experience, and as I say, social norms related to share and discrimination. There's a lot of rural to urban migration of men, leaving women in rural areas to do these menial kind of jobs with limited access to technical support, limited access to credit. And when they do own land, which is rare, the land that women often own is land of poor quality in most instances. There's problems with lower remuneration compared to males, especially in Northern Africa. The gender wage differential is high, with women earning about 17% less than men do for those reasons that I've just cited. As I say, some of it not just justified by these, but because of sheer discrimination, which is unfounded, basically. And some of the regulations and practices that are not supportive to advancement of women. Working poverty. Most of the women that work are still poor. In fact, too many women that are in jobs are in menial jobs that don't make them come out of poverty. There's also poverty-induced child labor in the continent. Physical infrastructure has to support whatever it is that we're trying to do to resolve these problems. We have to, in the context of dealing with general development in terms of roads, bridges, schools, clinics, social care, all of these things need to be done at the same time together. So there are serious issues regarding equality and opportunity. There are opportunities for intervention along the whole continuum of care on maternal mortality and morbidity for the benefit of not only the women, their families, the community, and indeed the economies of their countries. There's just a few socio-demographic factors that have been referred to earlier. Children of less than 15 years constitute about 42% of the population. And you can imagine how that translates to teenage pregnancies and therefore poor outcomes in terms of infant and child and maternal mortality, with high fertility rates in some instances. And I'll just skim through to some of these slides because it has been referred to earlier. In terms of health systems specific issues, there's inadequate health force in the continent, shortage of midwives, weak intersectoral collaboration, poor service delivery and utilization, inadequate health financing in some instances. There's only about 4 countries or so that are actually meeting the Abuja 15% commitment of national budgets that should be allocated to health. Poor coordination of interventions and unfavorable legislation. But even as we paint this gloomy kind of picture of the continent, there's some good news about that continent. There's oil in Africa, there's gas, there's precious materials and other resources. We are seeing now increasing trade within the continent and internationally. Economic growth is in fact expected to climb after this recent economic growth slump. Turnover of African banks and corporates is increasing. Domestic revenues and foreign direct investment, remittances, and official development aid has climbed recently over the last decade. Progress with MDGs, unfortunately, is slow. Although, therefore, what this says is, although this growth and all of this development is necessary, it is unfortunately not enough. It's not adequate to turn the tide, not sufficient to turn the tide to accelerate progress, especially in MDG 4 and 5. So there needs to be improvement in the quality of lives of every African woman, child, and man. Is the growth that we're talking about exclusive, perhaps? Does it reinforce and result in inequality? Has it failed people in rural areas or people in search of work? These are the questions that we need to confront and address. How do we then turn the oil, the gold, the diamond, the nice things, and gas into results? What about my country that's at the tip of the continent? South Africa with its 9 provinces. Just briefly to say, recently, Stats South Africa released the midterm year population estimates, which puts the total population at about 50 million at this currently, with about 51% of those being female. I thought it would be important to look at the life expectancy for males and females, slightly better for females at 55 and 53 for males. But look at the infant mortality rate of about 46, and HIV prevalence continues to be a problem in that country, high HIV prevalence. I'll skip that one. So what do we know really about this particular problem in the country? We unfortunately don't have good data in terms of vital statistics, so we rely on facility-based audits, and those are the 3 reports that we use. But these reports we use so that we can effect changes to improve services, especially in the health sector. So what do we know that's coming out of whatever those reports are saying? If you look on MDG 4, yes, as you can see, we about anywhere between 69 and 76 per 1,000 live births for child mortality. And if we're looking at reaching MDG by 2015, we need to reduce that by about 60% in the next 5 years. So we need to think about what are the things that we would need to do to get there. If we look at what we're talking about today, MDG 5, and there's data from South African Demographic Health Survey and the records that we have from facility-based audits, census of 2001, it can be anything between 230 to 575 per 100,000 live births. We need to get to 38, so it's a tall order indeed that we are faced with. So
5 minutes in a minute.
5 minutes left. In that 5 minutes, I would like to briefly just say why mothers die in South Africa Africa is largely basically driven by HIV. And if you look at the combination of the pregnancy-related mortality, it's hemorrhage and hypertension. I'll leave out the children at this point, but just to say we have identified the big 5 causes of death in South Africa, mainly and namely pregnancy and childbirth, newborn illnesses, child illnesses, HIV and AIDS and malnutrition. We have done fantastic work implementing some of these programs. As you can see, we're doing well with knowledge about HIV and AIDS. Women do actually have access to skilled attendance. Women do attend antenatal care services, but something is amiss along the way, and we think that the top 5 of the big 5 sort of causes, health system causes, are those that are outlined there. Lack of transport to and from institutions, inadequate facilities, inadequate skills, and lack of caring attitude. So we have this paradox of high coverage and poor outputs, and we think that district-based primary health care programs would be the solution for the country. And we think we should target communities, we should target healthcare managers, we should target also healthcare providers with all of those strategies. We've identified some of programs that work. When we fortified bread with folate, we saw a reduction in neural tube defects. When we introduced the kangaroo mother care, as you can see, it's a young lady who has a preterm baby with all of the possible challenges that are linked to that. But when we introduced the kangaroo mother care, there was a reduction in mortality of babies. When we changed the testing policy for HIV, it initially used to be only 15% of mothers agreeing to take the test. Now, when we introduced opt-out and policy has changed, as pushed by politicians currently, that uptake for testing increased to 85%. And we have outlined what we're wanting to do going forward from 2010 to 2015. And that slide, when you look at it later, outlines our targets, trying on our way to meeting the MDGs. These beyond health systems kind of turning resources into results for people, recommendations, come straight out of the report of progress, Africa Progress, that group of leaders that is led by Mr. Kofi Annan, and it is constituted by eminent people globally. I found that actually quite useful for this discussion today, and I'll run through, just skim through them. Women need to be given greater access to control and ownership to resources. Women need to be at the center of climate-proofed development strategies. As we talk about these challenges, how are we mainstreaming or genderizing those solutions so that women are a part of that? Women empowered are key to increasing industrial productivity. We need to harness women's entrepreneurship, both in formal and informal economies. We need to have connected women. Connectedness, as you know, is key to effective access to markets and all of this. Educated women, we can't overstate that. Gender discrimination, we know, is a big break, and we need to confront and deal with that. Women do add value to policy development, so they have a better understanding of these issues and can guide where all of these things are going. African women must be adequately represented in international fora so that we create these synergies, maximize these synergies, reduce apathy, and speak for vulnerable groups. It continues to say there needs to be regional solidarity amongst women. Protection of women should be at the heart of, even as we talk security. When incident happened in Kampala, Uganda, what was the role, or what could have been the role of women in dealing with that challenge? And others. There continue to be situations of conflict, and what is the role of women in those situations? African leaders need to advocate for fulfillment of commitments. We're talking G8, and they talked about 10 billion, and others. There's many of others that we are aware of. Women empowerment should be a specific objective of partnerships, and policy coherence should be built with Africa's women in mind. And in terms of us being here discussing the Global Health Initiative, we indeed do welcome developments in this regard. We note the principles, the targets, the commitments, the strategies, and the approaches, but we would like to see more multi-layered kind of harmonization at global, regional, and national level so that we get best out of all of those interventions. So without much ado, then I'll stop there, Tim, and thank you once more for inviting us. I'm happy to take a discussion on this.
Thank you so much, Dr. Kundu. Any student of African health policy, and specifically South African health policy, has a rich resource here in Dr. Kundu's presentation, which I also encourage you to, again, to reference online. Great stuff. As Dr. Kundu was talking, I was reminded of a statistic that DFID put out, which I pulled up recently, is DFID being the UK Department for International Development, saying that women bear the African rural economy on their backs, carrying 2/3 of all goods that are transported and producing 60 to 80% of all staple foods. You can't argue against a statistic like that in addition to what you just talked about, Dr. Kundu. So thank you very much. I'd like now to turn this over to Mary Ellen Stanton, who is the Senior Maternal Health Advisor to the United States Agency for International Development, an organization I think some of you have heard of. She guides the Bureau's maternal health portfolio, including the design and evaluation of country programs and research. Mary Ellen is a certified nurse midwife. She has decades of experience in clinical nursing and midwifery, nurse midwifery education, and international maternal health programs in more than 25 countries. She helped launch and now manages the USAID Fistula Repair Program. And I think Mary Ellen's going to bring us a valuable perspective on foreign aid and donor perspectives on the case for maternal health. Thanks, Mary Ellen.
Hello, everyone. It's really a pleasure to be here. I'm delighted to be invited by the Woodrow Wilson Center and to take part in the Maternal Health Task Force series and discussions with the Woodrow Wilson Center. And Kaylin has always just a wonderful job in managing this process. So kudos to her. What I wanted to do today is really talk about two things. One is what I was asked to talk about, which is the investment case for tackling maternal mortality and morbidity from a foreign policy perspective and an economic perspective, but I couldn't leave out the social, so it's in there. And then I just wanted to say something about looking ahead, that if we're actually successful in getting the investments that we've demanded, and as Dr. Kundu so comprehensively outlined how much is going on now, this has to be our year, huh? Foreign policy case. I've drawn from a couple sources, so it isn't just Mary Ellen talking, but parts of our government who would have something to say on this. And here, this is from the International College of the Armed Forces, the Department of Defense. And they're saying that U.S. has a national interest in advancing well-being and prosperity of other countries, and if we do so, their countries will grow economically. Therefore, U.S. leadership and health leadership can lay a foundation for this, for economic growth, and also, from our U.S. foreign policy perspective, for goodwill to the United States. Specifically, it is quite interesting that the Industrial College of the Armed Forces actually names maternal health and says that has tremendous appeal. It's very helpful to hear from a source such as that, to come by something that may seem softer in some circles, to worry about mother survival. But for the very reason that Myra started out with, this is the right thing to do. The altruism, even before what it can do for us. And it brings in what we do in relation to working with private sector, innovative approaches, and so forth. Now, from our UN National Security Strategy, dated just 2 months ago, that we have a strategic interest in promoting global health. This has come to the fore, and we have seen this through the President's Global Health Initiative. And in terms of women, they supporting the rights of women and girls. And those of you who know about the Global Health Initiative know that one of the central principles is to have women and girl-centered approaches, so that there comes to be a position of equity, and that this strategy says the experience shows that countries are more peaceful and prosperous when women are accorded full and equal rights. So we've got strong support there. Now, when you were all invited to come, in the blurb it said, and USAID says that if we don't address these problems, it costs $15 billion annually. So I thought maybe you would want to know where that came from, because I probably have had 5 to 10 phone calls coming up to the Women Deliver conference about where that came from. And it actually came from analysis that we supported back in 2000. It was called the REDUCE model. Later it became Reduce Alive. But it looked at the direct causes of mortality, such as postpartum hemorrhage, indirect causes, such as anemia, and other conditions. In this case, happened to be tetanus. And it was based on the 1995 UN estimates of mortality and at that time what was available, the 1990 global burden of disease. And assumptions were made for each and every complication. Hemorrhage, incontinence, fistula, and so forth, and making assumptions about case disability rates, average onset and duration to calculate a productivity loss. And the calculations come out with about $7 billion annually for maternal disabilities, considerably less, about 1/10 of that for the maternal deaths, and then over $8 billion for child disabilities related to maternal as well as newborn ill health, and it came to that $15 billion estimate. So there was that estimate, and then Women Deliver in the before the first Women Deliver conference, Gil and others did a very nice analysis of what had been done in terms of how much it would cost for additional scaling up beyond what we could currently see at the time to get to MDG goals. And as you could see from this chart, there were 3 major efforts to do this. In the Lancet Neonatal Series, in the World Health Report from the WHO in 2005, and on the Commission on Macroeconomics and Health. They all had different interventions and scenarios, what would be covered, how much coverage they were projecting in how many countries. They were all high-burden countries. And the annual cost, additional cost, ranged between $4.1 billion to a high of $6.1 billion. Now, a couple of those, so that would be a gradual increase over time, that no place could absorb all of that right away in about 2006, 2007 when it started out. The clear implication of this is that even at the high range, at $6 billion additional cost, it's a whole lot less than the $15 billion lost from the Burkhalter reduce analysis. So that it makes sense. Now, what I wanted to do is I want to take a couple country examples, and this relates to what happens at the household level. There's the work in progress. This is from a working paper that was done as part of a very big study in Bangladesh to determine the social and economic consequences of maternal ill health. And this is just one part of that overall set of studies. And it was to determine the costs, which have been determined in a number of different places, the effect on the economic condition of the families, and how households cope. So the first part of this is the spending. And they divided up severe complications and less severe complications. And severe would be a postpartum hemorrhage, less severe would be bleeding of some amount. So there are all of these definitions in. And it wasn't decided just by the woman's report. There was expert physician review of records and examining women. And what they found was that there's a considerable loss of resources up to 6 weeks postpartum with either a severe or a less severe complication. The level for these two types of complications around 16,000 taka, which is about $230 US, substantially more than what a non-complicated birth would come to. Now, what did this actually mean for families? In the top line there, in income and savings, for a normal delivery, families were able to cover the costs of normal delivery about 2/3 of the time from their income and savings. But if there was a complication of any sort, 30 to 40% of their income and savings would cover that, and they would have to go to other things. And as you can see here, with complications, they went to loans predominantly, but also got donations and gifts from friends, or they sold some of their assets. Some of the conclusions that they came to is that the household costs of seeking care are high, and the burden, not surprisingly, is greatest on the poorest. That when there's a maternal complication, 2/3 actually incur catastrophic expenditure, which is defined as more than 10% of the household's annual budget. So it's really quite substantial. In the poorest quintile, they were spending 30% of their annual income on that complication, as compared to 8% for the richest quintile. And in the case of a complication, they had to borrow the equivalent of $113, where they only would have in their budget a little less than $200. So it's very substantial. What the families did is they went and took out loans. And in some cases, this really suggests a very desperate way to cope with these high financial costs to pay. In Bangladesh, where this study took place, and we have to say that it's where that study took place, the good thing is that they didn't cut back on consumption. They didn't cut back on number of meals or the type of consumption going along with that. I was just in Burma in the dry zone, where they're experiencing great economic hardship, and they are absolutely cutting back on meals and what's in there. They're living on rice and leaves. So in this case, we see that there are other ways to cope. But the poor really need protection. And the authors of this study talk about demand-side financing, but being very cautious about how we do that. And I think we could talk later about some solutions. I wanted to use an example, and it's a very qualitative example from Bangladesh. And it comes from Jeff Smith from Japaigo, and this is a real story. This is not a made-up story. A man, not in Bangladesh, in Afghanistan, whose wife delivered twins and during the process died in childbirth. Now, we always think of the funeral expenses and, of course, the hospital and medical expenses and sometimes transport to and from. But this instigated a cascade of things that happened following. There were, of course, lost wages for the father. Then, as we know all too often, the daughter drops out of school to help do household activities and care for these twins. In this case, there were milk expenses. Then the boy dropped out of school. So now we had two children who were losing education. The little one of the twins died, and there were medical expenses. The father, not surprisingly, remarried, and there were marriage expenses. And then there was this catastrophic event later on with the surviving twin dying. This is so improbable. This is a real story of giving birth to a brain-damaged child after a long labor, and she having a fistula. Cast out by the husband and returns to her father. All of this leads to family debt and impoverishment. And what didn't happen in this case, but happens in other times in Afghanistan and in other societies, when families incur this crushing debt, they sometimes sell off their daughters. So that's why I couldn't leave the social consequences out of this. So the case that the other speakers have built, and these case of the country examples lists, well, what is the U.S. government doing? What is aid doing about it? And I can say that since the year 2000, this graphic starts at the year 2000 and goes to the last bar here. All of these, except the last one, are enacted budgets for family planning and reproductive health, which contribute to maternal survival, and maternal child health, including nutrition, a good portion of which is maternal survival. We don't have an absolute number. So in 2000, we had, in total, in these two accounts, 735 million. It's up to 1.3 billion. And the request level for going forward to fiscal year 2011 is 1.7 billion, reflecting the President's interest in ramping this up in the Global Health Initiative. I have to say it's in a climate of worries over our debt and a lot of concerns over budget increases, so we don't know what will be gotten from this. I think what we can say is that the President, the administration, is seized with this, and that even prior to this year we had growing interest in terms of more money from the Congress, so that we have people in both the administration and the legislature that have, I think, gotten the message.
5 minutes, Miriam.
Okay, good. That's just perfect. So what if we got more money? Marge Kablinski and some of our colleagues at the AIM project have dug into recent DHSs, and they've picked out, for this purposes of this, countries in Asia, where there were two studies, the first done around in a time period around 1998, and the other in more recent time ending in 2008. And what we can see here is that the private sector is the site of a substantial and growing proportion of facility births. Now, I don't know if this surprises anybody or doesn't, but what's going on out there is really quite remarkable, and I imagine in the next set of DHS, that we can only imagine that this trend will increase. There will be more births in facilities, and there will be more, increasingly more in the private sector, which has consequences for funding. In my mind, I link this up with once you go to a facility for birth, then people might decide that you need something that costs money because they want to help you. And cesarean section is countable, and there has been quite a growth in private cesarean section births. And that what this shows is that it is in good part responsible for the overall rise in cesarean sections. Now, why should that be important? Why do I bring that up here? I think it really is important when we look at the costs, the funding requirements that's going to take care of the women who now have gotten the message that there's a good foreign policy case and there's a good economic case. Take you just the U.S. experience. The maternity care is the leading cause of hospitalization and office visits. That medical procedures relating to pregnancy are the top 3 billed procedures to Medicaid. We know that we spend a huge amount of money on our health expenditure, the greatest of 30 OECD countries. And meanwhile, some of our trends are headed in the wrong direction related to preterm births, low birth weight, and that we rank behind 29 other countries in maternal mortality and neonatal mortality. The message is you can spend a lot of money on maternity care and not get all the results that you want. Now, would this be anything like what's going on in countries with high burden? Well, in WHO regional surveys, they showed, and these are hospital-based C-section rates, and not all women are in hospitals yet, but we know there are a lot of financial schemes to get women in. In Latin America, very high C-section rates at 27%. Probably you know that WHO says the C-section rate should be between 5 and 15%. So there it is at 27 with high use of hospital birth. The new surgery, or 33% in Latin America. The new study that came out in Asia is up to 27% in hospitals. It's not where it should be in Africa, and there's always maldistribution in countries. So we've got to figure out the maldistribution. It isn't just international. But these C-sections cost as much as, between, where I could find data, between 2 times as much as vaginal births to as much as 18 times as much. In my Mauritania example, I was just out in Burma, and it was 12 times as much. So that we could get a huge amount of new investment. We could draw a lot of people in for services, have it cost a lot, and then still, as these WHO studies showed, some evidence of poor outcome with all of that. So I think that we need to invest wisely to eliminate the barriers, financial, geographic, social, to give quality care, and at the same time guard against incentivizing expensive, invasive procedures that can drive up the costs. So maybe those estimates of what it would cost to give additional care would soon skyrocket, and possibly could contribute to adverse outcomes for some. I think I want to wind up by saying that not investing in maternal health, including family planning, brings a lot of unwanted consequences, not only in quality of life and risk of death and possibilities for abortion, but also on decreasing women's productivity, their chance to engage in civil society, to promote good governance and security. Mahmoud Fatala, I was looking up last night to try to figure out when he said it. I believe he said it in 1987 at the beginning of the Global Safe Motherhood Initiative. It astounds me that we are here in 2010 still having to make the case. But we will continue to make the case. I am very hopeful that now we are really on the verge and that there's momentum behind doing something about this, and so that by 2015 we will have, if not having met the MDGs, which would be very hard in terms of maternal health, to see a lot of countries that have, and see a lot of progress in those who haven't yet made it. Thank you.
Thanks, Marielle. And I think we can all agree that we're grateful that she did not follow directions, because the social determinants and the consequences are really compelling stuff. And the story from Afghanistan, I think, will give us all pause. And I know that was 1987, the Safe Motherhood Initiative. I have that cited as well. So, from Mahmoud. Great stuff here today. I think we can all agree we have a pretty well-rounded, diverse perspective on the impact of economics on maternal health. With these policy dialogues, we do want to encourage dialogue, and that is now we've now come to that section of our event today. So we're opening the floor to you. There are microphones that are going to be circulated around. I see two people who have appeared with microphones sort of magically. And I'd like to open the floor to all of you to address questions to our esteemed panel. It's an excellent opportunity. Please raise your hands if you have one, and we'll get the process going. I see one person over here.
Thank you all. It was a very interesting discussion. My particular question is for Mary Ellen. It was a very interesting point that you made. We do have a lot of traction now in maternal child health, finally, and people are investing more. But it's scary to hear about possibly where that investment would take us and the detriments that would occur. So my question is, what are your suggestions for investing wisely? There's recent quick wins of birth asphyxia discussions from AID and things like that. I was hoping that you could talk about some other ones, perhaps.
Well, I think in terms of quick wins, one of the most logical things is to do at the look at the direct causes of death, and where they're proven high-impact interventions, such as active management of third stage of labor, misoprostol in the community, getting women magnesium sulfate when they're severely preeclamptic, eclamptic, post-abortion care. That is the logical way to go, to scale up the proven high-impact interventions. It's not always so easy, but I do think that in our desire to give comprehensive care and do everything, we've maybe been a little behind in keeping the spotlight on a few things that save lives. At the same time, we've got to move ahead with all of those health system things that really make a difference, and that means, in terms of human resources, fully qualified birth attendants. We've used the word skilled, and there are many definitions, but even if they are competent, put in an environment that's not enabling is difficult, so we need to make strong decisions. The one more thing, I think one of the most exciting things that's going on but needs careful watch is the financial fixes to reduction of the financial barriers to care. The cash transfers in India, the social safety nets in Indonesia, the health insurance in Ghana and Rwanda. So many things are very exciting. They're getting differential results. And we have to look very carefully at whether they're actually improving the health outcomes, not just moving people during the course of labor to an environment where they may and may not get compassionate, high-quality care.
There.
Hi, everyone. My name is Halima, and I'm from Niger, an intern at the United Nations Foundation. I think reproductive health is something that's quite touchy in a lot of countries, mine specifically. And I was quite surprised that the role of religious leaders didn't come up. So I was wondering what you think the role, what role you think religious leaders could play in national programs, but also in the kind of policies or programs that are being designed here in Washington or at your institutions.
I'd be glad to try that. We have done USA work with a lot of work with religious leaders. If Maureen Norton were still here, she could talk eloquently and at length about this. In the area of family planning, which is sometimes considered touchy, there are Muslim countries where we have worked, such as Egypt, extensively with Muslim leaders. In some countries, they've issued fatwas in favor of family planning so that mullahs can give that message out at Friday prayers. And as I sound like I am from the U.S. government, but a bit of a spokesperson on this, President Obama, besides the Global Health Initiative, he announced an initiative in global engagement. And that is working with religious leaders of Muslim groups and in both polio eradication, but also in maternal newborn health. We are starting just this year to work with the Organization of the Islamic Conference, to work with religious leaders and religious organizations. But this isn't just starting up. We have a history of it in many countries, and what we found is many of these leaders are really receptive.
Anybody else want to respond?
Yes, perhaps I should just add and say those health sector related kind of activities to expand family planning activities need to be supported by community-based sort of mobilization programs that include the faith-based sector in terms of educating them on the importance of doing all of those things, but also the importance of educating girls and keeping them in schools. We've seen the data, supporting the importance of that in terms of decision making on fertility and transitioning to sexual activity issues, as women are kept in school and able to make those kinds and take those kinds of decisions. That should be part of a comprehensive approach to it as we engage meaningfully with faith-based sectors in communities.
Just another plug. This series will be addressing religion and the linkages between faith-based leaders and faith-based practices and positive maternal health outcomes in a future incarnation. So stay tuned for that. Sarah, other questions here? I see one in the back. Right by you. Oh, okay. And one behind you. But we'll go here first where the mic is.
My name is Diane Coraggio. I'm from the Johns Hopkins School for Public Health. And actually, to piggyback on that, if you're interested in a program, in Pakistan, we recently did an ulama intervention where we educated the ulama and involved them in getting out messages about maternal and child health to the men in the community specifically. Which brings me to my question. I work mostly in Asia, and we have a really difficult time. There's a fine line between involving women and then making men feel like they're still making decisions. And so I was particularly interested in South Africa, and what's the situation there in involving men in maternal and child health?
It's certainly an area that we can do more in, but policy-wise, we have realized, as we had discussions at home and in communities, the importance of engaging men as partners, as equal partners in assisting us making these kinds of decisions. It came out strongly, in fact, when we were struggling dealing with the spread of HIV in South Africa and the dynamics of gender relations in a sexual relationship, male and female, and the ability of women to make those decisions. And we have organizations called Men as Partners that are actually leaders and they're educating themselves about their role in assisting governments reach objectives in relation to health and reproductive health, but also in dealing with HIV and AIDS. So we do have those organizations. In fact, in the area of HIV and AIDS, in the South African National AIDS Council, we do have Men as Partners as one of the sectors that is represented there in a meaningful kind of way. It's obviously work in progress.
In the back.
Good afternoon. I'm Tandi from the South African Embassy. I just want to find out from the USAID, knowing that you have been in the field for quite some time, and when one was looking at the statistics that were presented there, it looks like there is slow progress in changing the situations, and already the statistics tells us that this, in fact, even the experts are they know what has to be done. Where are the problems generally? Is it a political? Is it cultural? Where is the actual problem? We know what is the problem, but it takes a long time to get it sorted. Thank you.
I suspect that there are as many answers to that in this room as there are people in this room. I think that it's simple to say that we know what to do because we have a scientific base for a lot of these interventions. In some cases, it's how to do it, how to reach women who are birthing at home in a way that actually increases their chance of survival. So some of it is very much a how question, how to operationalize in settings. I think that even if there's money and there's a good plan, there is the issue of leadership, of how to get started, how to manage things, how to monitor, how to appreciate those who are doing the hard work and galvanizing the others to follow. I always think of Raj Karim, who I think was the architect of the program in Malaysia that brought maternal mortality down. And as she wrote it up, she said something along the line, it's not a direct quote, so you can't underestimate the importance of hard work, that it's really a slog. And that means galvanizing a whole lot of people to keep at it and to do hard work in these environments where we know the salaries are not consistent, they're not enough, the work environment is difficult at best. So I think these are some of the challenges that need real leadership and resolution. But I'm sure all the others have ideas on this.
Dr. Kunde?
Yes, I would add and say I think the topic of the discussion this afternoon actually gives an answer to the question that is being raised from the South African Embassy in terms of empowerment of women in a comprehensive kind of way so that they are part of progress as nations address their problems, so that they're able to take decisions about their own lives, about when whether to get married, whether and when to have a baby, how to look after the baby when it comes, and all of those things. I think that key to all of that is just engagement and involvement of women in progress, in human development in general, so that they're able to make those decisions.
More questions from the floor. Soumya. There's a mic coming.
Oh, thank you. My name is Soumya Ramarao from the Population Council. Thank you to all the panelists for an excellent session. I wanted to highlight what Myra was saying about the investments that one needs to make, not only within the health sector, but other sectors, which have an influence on not only well-being, but health. Example, particularly those that affect transitions to adulthood. As Dr. Kundu was saying, if you can delay age at marriage from, let's say, the 12s and 13s and 14s to a little beyond, so that age at first birth is delayed, that's a social sector intervention, which will then have health effects. So I think we do need to pay attention to those sort of interventions as well, in addition to direct interventions that you were suggesting, Mary Ellen, which are the easier ones to implement because we know those medical interventions exist. So thank you all for your panel discussions today.
Yeah, and thanks for that comment. No, I was just going to say that in terms of why things haven't moved as they should have, and I think that three factors are critical. I mean, one is leadership. I mean, and there has not been, at the level of country leaders, of governments, this has been off the radar screen. There have been, there have been leadership in other areas, but this area has not been. And now, fortunately, now with things like Women Deliver and whatever, it's picking up. The second thing is finance. I think that, at least in terms of the World Bank, financing and lending for health systems in general, has decreased dramatically in the last 10 years. And, so which means that governments, because the bank is a reflection of what governments put priorities on, governments have been interested in borrowing for other things. And the third thing, I think, and that refers to what you were saying, I mean, it's, we have been very concerned in affecting the supply of health services, but the issue of demand is terribly important. And that's where I think that there's a lot more to be done. So to increase women's and girls' demand for these services. Thank you.
Right here.
Yeah, Marge Kablinski with JSI. And I would just say we shouldn't be quite so pessimistic. There have been some countries which have really moved very well. Look at Nepal, look at Indonesia, you look at parts of India. There's been major movement towards improving programs and some results which are quite encouraging. I think one of the big issues around maternal mortality, however, is you can't measure it all that easily. And so everybody gets very concerned about the confidence intervals overlapping, et cetera, et cetera. But essentially, there are examples, and if you look closely at some of these countries, and I've only mentioned a few in Asia because that's what I know, you can see movement, you can see some success, and you can see leadership. So I wouldn't be too pessimistic.
And as we've said, there is a great deal of momentum underway. Is there a way we can get a microphone right up front here? There's not only advocacy momentum, there's also policy momentum, as I think we saw from Dr. Kunde's presentation, a great deal of policy momentum. Sir.
Yeah, thank you so much. My name is Abdelhadi Al-Tahir. I'm advisor for maternal and newborn health with Pathfinder International. Thank you so much for the Maternal Health Task Force for coordinating this and for bringing such outstanding and inspiring panel. And the presentations are really excellent and very stimulating. And I think it's really enhancing a lot of, there is a lot of content in this addressing maternal mortality. My question to Dr. Kondo about the recent summit of the African Union, and I think that is an excellent start, or for the first time the African continent to take some sort of initiative to enhance the political will, and I hope that will be like infectious to all the policy leaders in the African leaders, but it seems like needs a lot of hammering. Is there any specific tools of having that being like really ensured to take effect that the political will in each of these African countries, who those who attended the summit. So that is one of the things. The other thing is your comments about Africa, South Africa. That is really, there's a lot to learn from South Africa. One of the things that is very key for maternal mortality is the maternal death audit, and South Africa is one of the most advanced countries in the continent. So is there any way of transferring that? Because many countries tried that and they stopped and set back because of the challenges of the maternal death audit. Thank you so much. Thank you for every the speakers.
Dr. Kunda?
Yes, thank you, Chairman, and thank you for that question. Yes, as I was saying, it's actually heartening to hear that coming out of the African Union Summit and heads of state right now. And the chair, as I was saying, of the African Union is now saying, we've had the declarations, we've had all of these decisions. Now we need to talk action. And more action. And I think that it's supported. It needs to be supported by all of the partners. And I think that there's a lot of, all of these initiatives that are currently underway globally, regionally, and in countries actually are on track to support that kind of momentum. The plan for the African Union now is to work with partners on the ground, with the WHO, with UNICEF and others, to assist countries to translate all of those into country plans. Most of the countries actually do have plans. I did outline some of the strategies that we have and the targets that we have outlined for ourselves and strategies to get there. We know what works in most of our countries. But now it's a matter of getting to do those things in an efficient and effective way that is supported, yes, by leadership, yes, as Mara was saying, by budgets, but also the metrics, the monitoring needs to be in place, and there's a whole lot of energy and concerted effort to do that now. In terms of the audit themselves, we started doing these we do it triennially. For maternal health, for child health, and for infant mortality. And we find that because we struggle with statistics, vital statistics, it has been a very useful tool in giving us information for planning and for improving on services. Often we get recommendations from the committees that are ministerially supported to do these audits. The challenge is to make the health system to respond to those recommendations, and that is the work that is currently in progress right now.
Over here, please.
Woody Kessel, University of Maryland. First, thank the panel and thank you for an inspiring afternoon. You began this panel, and I thought it was a very important point to underscore about the interdependence of taking a multi-sectoral approach to the solution of a particular problem. And I guess that's really where my question is. In our typical approach to problem solving, we tend to deconstruct the problem, and then we end up with multiple disconnected categorical solutions. So my question to the panel is, how do we sustain, how do we encourage a systems solution? I thought the point about health influencing economics and economics influencing health is absolutely critical. We could probably list other sectors as well, but the question becomes, how do we not lose sight of this interconnectedness, the interdependence of this, and sustain multiple approaches to actually resolve the solution rather than taking an individual approach and celebrating, frankly, the critical successes that we need?
Thank you. Who would like that one? Dr. Kunda?
Let me try. I think it's a brilliant question, and one that we really need to carefully think about in terms of the best approaches. What we're doing in South Africa, we have at the presidential level a National Planning Commission, which has now taken what we call an outcomes approach, and the health sector is part of the human development sector. The government is organized in sectors, is part of the human development sector. So we also have in the presidency, we're developing the National Strategic Plan for better life for all South Africans. So the competitive advantages of all of the different sectors are designed to contribute towards the attainment of that defined kind of vision of a better life for all. So health sector will come with interventions that are specific to that sector, implementing in areas that they have competitive advantage, but communicating with other sectors in terms of your economic sector, agricultural development sector, infrastructure development sector, discussing how best each can contribute towards the attainment of the broader sort of high-level national goal of better life for all. So it needs to be coordinated at a high level, and we're putting that in the country at presidential level through the National Planning Commission.
Any other comments? Myra?
Well, I will say something different. So, I mean, I haven't seen it in the area of health. I think it's a very good question, and it's a very difficult thing because, you know, simple solutions are best in terms that they get implemented more easily. But there's a similar problem with violence reduction that I am very familiar with, and the only way that you could coordinate, because violence reduction, again, you know, you need solutions in many different sectors, and you need to involve ministries of health and ministries of the interior and the police. And the only way it has worked there in violence reduction is at the provincial level. I mean, it's at the level, either at the level of a city that is able to organize things, or at the level, so it's local level governments that, you know, can coordinate better things that, you know, at very high levels, at the level of the nation, it's more difficult. But, you know, but in the case of South Africa, you know, it may work at that level too, so.
Oh. I can see how we get segmented and attribute, well, Congress sends us money in certain lines and there's guidance for the use of money. But I have to say that we need to keep learning more. I'm utterly taken by this information that I never knew, that giving money to adolescent girls keeps them in school and delays pregnancy and all of this stuff. It's so powerful. And it's so striking that I want to find a way within aid in some kind of collaborating to link up with something that works so powerfully. And I think that's part of this, to keep learning and keep getting energized by new ideas. And some of us will try to figure out how to make it happen.
I know the moderator is not supposed to interject, but I will say that the last meeting we had here on transportation and referral for emergency obstetric care, one of the outcomes of that meeting was that challenge will not be solved in one ministry. That is, by definition, a multi-sectoral, intragovernmental challenge. And so your point is very well taken, even to a specific response in maternal health. As you can imagine, transportation referral is communications and roads and health and finance. So point well taken. I think you've got us all exercised on that one. What is there couple last questions before we yes, one more from?
Yes, one more.
From Niger. Good.
Yes. I think with 2015 looming, coming closer, it's clear that some countries are not going to make it for the MDGs, especially with the ones relating to women. I know my country won't, unfortunately. So my question really is, what do you think the post-MDG 2015 picture should look like, and what could we do differently to sort of make sure that at least within maybe 5 years or 10 years, to be realistic, we sort of reach some of these goals?
So what happens post-2015, panel? You have 4 minutes. I think you've got us on that one. It's a big one, and I think that there is a great deal of conversation underway among advocates, among policymakers, among all the stakeholders about. We've been working very assiduously towards 2015. There will be 2016. What happens then? I'm not sure if any of us have answers to that. Mary Ellen, do you want to try it? I see you're nearing a microphone.
Well, I was thinking what's ahead, and it doesn't have to wait till 2015. But I think that in the maternal health field, that we've been struggling with really inadequate indicators, and that the indicators can drive a lot of action. And what we've had are indicators that are pregnant, childbearing women's contact with services, skilled birth attendant, antenatal care, and so forth. Unlike in family planning or child survival, where the indicators actually are the high-impact intervention that works, the immunization, the adoption of a family planning method. And so I think that we have a ways to go, and that if we can focus on some of those things, it doesn't all get reduced to high-impact interventions, but we are so still very bad at measuring them and therefore holding ourselves to account on them. That's a way that we could make some, I think, very important change on getting further to where we want to go.
Yes, let's have last word from each of you, if you may.
Okay. I would say it's a good question to part with. I think by the time we get to 2015, we will have a good sense of the nature and the dynamics of the problems. We will have a good sense of why we didn't get where we had meant to be. And I think it's becoming clearer already now, in my view, as we're talking about multi-sectoral approaches. I think that it's clear disease-specific approaches are not adequate. It's clear that growing economies, as we're talking now about maternal mortality and economies, is not enough. It's necessary but not sufficient to get us to where we need to go. I think that we need to press on with advocacy for this multi-sectoral approach to dealing with challenges but also ensuring progress. And the challenge related to that, I think that we've done a lot of work identifying the pathways, and we need to use that data to assist us find appropriate indicators and organize globally, regionally, nationally to speak in that kind of language as we deal with these complex challenges.
Laura?
Yeah, I just wanted to add that, the good thing about 2015 is that there's a target and there are goals and indicators. And this is one of the very good things the UN system has done, really. We won't get there, but we will know who does not get there, and I think that will be an impetus to continue working. But, it is very good to have a date, a target, and to measure and see where we are. That is really in itself, I think, will be a motivator for action. Thank you.
Excellent. And on that note, we will adjourn today with a huge thanks to our panelists who I think have given us a